Hello students, I'm the OGGuru Dr. Punit Bhojani here with a single point agenda to make OBGY your most favorite subject, most scoring subject. Very important video, top 10 OBGY PYQs for the upcoming NEET PG examination. Stay right till the very end. We're going to discuss all types of questions, clinical cases, one-liners, image also I'm going to show you. These are very important PYQs, surely going to be repeated. The concepts will be repeated. And feel free to get in touch with me on phone and WhatsApp on this number. And 3 months masterclass combo, the NEET PG combo, which contains the main lecture and the rapid revision, only at 1349 is available with free extension till the August examination. So please download the OGGuru app and feel free to get in touch with me on phone and WhatsApp on this number, and you can master the entire OBGY in around 4 days time. You can master the OBGY and your score in OBGY is going to jump up from 10, 11, 12 currently to 17, 18, 19 is my guarantee. It's a very, very important topic. 20 to 22 MCQs come every year in OBGY. Let us begin our discussion. The first, very important. A patient has come to the OPD, female, 22-year-old, missed periods, vaginal bleeding, pulse BP given to you, okay, 80, 120. So it's the longest clinical question. So when such a long question aata hai, students panic. Okay, so you should know what are the important points which you are supposed to read in the question, and see how I will explain you and make it very simple for all of you. So pulse BP is okay. Soft uterus, no tenderness, and no adnexial mass. That's an important clue. Bleeding is there. Beta HCG given to you. So now we are sure that there is pregnancy, because in the first part we just know missed periods. Missed periods could be many things, but now the beta HCG is positive. Ultrasound, empty uterus. Now what happens is, moment students see that the beta HCG is positive, and along with it on ultrasonography the uterus is empty, majority of students will only think of ectopic pregnancy, isn't it? Yes, we are supposed to think of ectopic also, but so majority will think of ectopic, and majority students will directly mark methotrexate as the answer. Clean, bold, wrong. Then some students will say, okay, let me not go for medical management, let me go for surgical management, and they will mark laparoscopy. Again wrong, clean, bold, dandy goal. So now please pay attention. What is this? That, sir, when we are doing a ultrasonography, yes, uterus is empty, but even the adnexia are normal. Please understand this. That will not be the case in ectopic pregnancy. Ectopic में क्या होगा? Beta HCG positive, uterus empty. Uterus is empty. Nothing is seen inside the uterus. But outside the uterus, they will say 2 centimeter, 3 centimeter adnexial mass is seen. Okay, and that mass is our ectopic pregnancy. That is mentioned to us in the question paper. Now here that is not there. Please understand this. Even on examination, they have said that there is no adnexial mass, and on sonography also uterus is also empty and adnexia are also empty. So what is this, my dear student? My dear student, this is pregnancy of unknown location. As of now, we are not sure. It is a big debate whether, sir, it is a intrauterine pregnancy or a ectopic pregnancy. Why? Because, sir, this vaginal bleeding, a patient with implantation bleeding can also happen. In intrauterine pregnancy also, threatened miscarriage can also have bleeding. If she is aborting also, spontaneous abortion also there can be bleeding. And of course in ectopic pregnancy also there can be bleeding. So bleeding is not specific. Bleeding can be seen in an intrauterine pregnancy with a threatened miscarriage or threatened abortion. And of course in ectopic pregnancy also, patient we can get a bleeding. Is it clear? So basically this is pregnancy of unknown location. We are not yet clear. It's an unknown location. Unknown location whether mainly it is an intrauterine pregnancy or ectopic pregnancy. That we have to finalize. Now please understand this. Yes, we can repeat USG after 7 days. Yes, we can do that, but that might be too late. Why? Because, sir, if it is an ectopic pregnancy, then in that 7 days, the ectopic can rupture. Okay. So rather than repeating USG after 7 days, which is okay, it is dangerous. We are not supposed to wait for 7 days. What is the best way? How we can do? Yes, please, there's something called as a Cadder's rule. Please comment in the chat box, say kya hai? And what we can do is that the fastest way, whenever there is a confusion, basically this MCQ is a confusion. MCQ is not a confusion. The question is a confusion. I'll tell you how to solve the question, and the answer is yes. Repeat beta HCG after 48 hours. That's the best way. Why? Because HCG levels are only 1000 as of now. So what will happen? How the beta HCG? Yes, sir. When the beta, because in a early, what's the rule? It's in a healthy intrauterine pregnancy, in a normal matlab ke healthy, healthy intrauterine pregnancy, the beta HCG will double. The beta HCG will double. Okay, so quantitatively, the beta HCG doubles every 48 hours. So just to give you a clue, and sir, if this is 1000 and after 48 hours, when I repeat the serum beta HCG, if the level becomes 2000, we are dealing with a intrauterine pregnancy and just continue the pregnancy. And then when I will do the scan, everything will be seen. We'll see the gestational sac, yolk sac, heartbeat, everything will be seen. An ectopic pregnancy, since it is a defective pregnancy, the HCG will increase, but it will not double. At your level, just remember, it will not double. It will increase, but it will only be like a 10, 30, 40% increase. So example ke sir, this is 1000. So after 48 hours, this will become like 1200, 1300, 1400. This is just an example. Okay. Is it clear to all of you? And also please comment in the chat box what can happen or what is your interference if the beta HCG drops down. That's the third thing. That's a PG level. Even if you don't know, that is okay. That what can happen if from 1000 the HCG level drops down and becomes 700, 800. तो क्या हो सकता है? Is it clear to all of you? So that is not very important. So basically, my dear student, ये पूरा question क्या है कि as of now there is a confusion. We are not clear, sir, whether it is a intrauterine pregnancy, or a ectopic pregnancy. Is this clear to all of you? And whenever we want to confirm whether it's intrauterine or ectopic, what do we do? Sir, we have to repeat the serum beta HCG after 48 hours and the mystery will open up. राज खुल जाएगा. क्या mystery will open up? कि sir, if the beta HCG doubles after 48 hours, then we are dealing with a intrauterine pregnancy. And if the HCG does not increase, not double, then we are dealing with a ectopic pregnancy. Okay, so if the beta HCG doubles, then we are a intrauterine pregnancy. And if the beta HCG increases but does not double, then you are thinking of ectopic pregnancy. And then of course, then depending on this, there are methotrexate criteria, then we can think of methotrexate. So do not directly give methotrexate. There's no need to do laparoscopy as of now. Yes, ultrasonography can be repeated after 7 days time, but the best and the fastest way is to repeat HCG after 48 hours. Okay, and please also comment in the chat box methotrexate when I give for ectopic pregnancy. Please comment in the chat box. Again, it's a very important PYQ. What is the sac size criteria and the HCG levels? Okay, only if the HCG is less than how much, and what should be the gestational sac, then I can give methotrexate. So this is not a question of ectopic pregnancy. Please understand this. This is not ectopic pregnancy as of now. This is a confusion MCQ, and to solve confusion of intrauterine versus extrauterine, and to solve the confusion, I need to repeat beta HCG after 48 hours. Is this understood? Now, very important. Primary gravida, she was diagnosed as a patient of preeclampsia at 30 weeks. Now at 30, again a clinical case. She complains BP is 170, 110, urine albumin +2. No convulsions at present. So she eclampsia? No. But very important, she is complaining of headache and blurring of vision. What is it? Okay, so please understand this. These are a cluster. There are five dangerous signs and symptoms which are called as the premonitory symptom. What are those 5 danger symptoms? Okay, जब OGGuru है तो ओ बी इजी है ना, क्लैप, ठोको ताली। ओ बी इजी है ना का मतलब क्या है सर? ओ इज ओलिग्यूरिया, बी इज ब्लरिंग ऑफ विजन, ई इज एपिगैस्ट्रिक पेन, एच इज हेडेक, okay, epigastric pain, headache, and N is your nausea and vomiting. So nausea, vomiting, epigastric pain, headache, blurring of vision, oliguria. When this cluster of symptoms are present, this patient is not only preeclampsia, she becomes impending eclampsia. Impending eclampsia. That means sir, abhi convulsion nahi aaya hai. Right now there is no convulsion, but the convulsion can happen anytime. So here this is no convulsion at present, so this is not eclampsia. If you make the diagnosis of this is eclampsia, it is wrong. This is not eclampsia, this is impending eclampsia. And now what is the next best plan, or what is the best thing to be done? Now please understand this. Here sir, we are only 32 weeks. So many students, sir, we will wait till 37 weeks. Wrong, clean bold. Please understand this, that whenever it is impending eclampsia, never wait and watch. Those who wait and watch, you'll have to go to jail. Why jail? Will put you in jail. Why jail? Because if you wait, mother will get convulsion, mother dead, baby dead. So please understand this, that जैसे आपने हिंदी पिक्चर में देखा होगा, डॉक्टर कम्स आउट ऑफ द लेबर वार्ड एंड गिव्स द फेमस आइकॉनिक डायलॉग, हम माँ और बच्चे में से किसी एक को बचा सकते हैं. हैव यू हर्ड दिस डायलॉग? दैट सर आइदर आई कैन सेव द मदर और सेव द बेबी. This kind of option is not even given to the relatives. Please understand this, that whatever may be the weeks of gestation, sir, here we are 32 weeks. By chance, if I change this 32 weeks into 26 weeks, 28 weeks, 30 weeks, the answer will not change. Is it clear to all of you? So let the patient be 22 weeks, 24 weeks, 26 weeks, 28 weeks or 32 weeks. Whenever it is impending eclampsia, that is the last day of the pregnancy, and we are supposed to go and do the delivery of the patient. And why delivery? Because please understand this, delivery is the definitive treatment. Only when I do the delivery, the patient's condition will improve. So we are supposed to do the delivery. So whom to save? Please understand this, that mother is more important. Why? Because if you save the mother, पीछे पूरा cricket team आ सकता है. It means afterwards she can have. So this pregnancy we may not be able to save. Okay, this baby we may not be able to save. But afterwards, if the mother is there, she can give birth to as many babies as she wants. So whom to save? Yes, Indian government says save the tiger. So save the tiger, save the lion, save the cheetah. Doctor is saying save the doctor and save the mother first. So please understand this, that delivery has to be done, because delivery is the definitive treatment. And most important words coming in the bracket, okay sir, the delivery has to be done irrespective of weeks of gestation. ये जो irrespective of weeks of gestation है, उसके बाजू में I am putting 7 stars, 5 stars. That's why I'm saying that let this question be 22 weeks, 32 weeks, 28 weeks, 36 weeks. I will not wait. So we'll do the delivery. But before I do the delivery, we will give the most important magnesium sulfate. Why? Prophylactic. So the patient has not got convulsion. Yes. So magnesium sulfate is not only for eclampsia, magnesium sulfate is also for impending eclampsia. This is prophylactic magnesium sulfate, which I am giving prophylactic to prevent convulsion, prevent maternal mortality, prevent complication. And again, please understand this, once I give magnesium sulfate, we cannot wait and watch. Okay, chalo Maxel de diya, wait. No, once you give the magnesium sulfate, we have to go for induction of labor and do the delivery. Never directly jump to LSCS. Yes, occasionally LSCS may be required, but mainly first you induce the labor. Delivery is important, and delivery, repeat why? Because delivery is the definitive treatment, and delivery has to be done irrespective of weeks of gestation. So now you know that if you wait and watch, you're going to go to jail. Magnesium sulfate, very good, but then deliver at 37 weeks. Sorry, wrong. You'll have to go to jail, because sir, from 32 weeks, if you wait till 37 weeks, mother will surely die, baby will also die. Okay, and start labetalol, of course, and then again deliver at 37 weeks, again wrong. So what is the answer? Sir, magnesium sulfate I will give. Of course, labetalol will also be given to control the blood pressure. Okay, magnesium sulfate is given to prevent eclampsia. Okay, is it clear to all of you? Why? Because sir, prevent eclampsia, because this is impending eclampsia. And of course, induction of labor, that's a complete plan, that's a complete thing, labor and delivery, because delivery is the definitive treatment. So magnesium sulfate to prevent eclampsia, labetalol to control the blood pressure, and delivery is the definitive treatment. Thoko talikla. Okay, and please comment in the chat box. Please comment in the chat box what is the loading dose of magnesium sulfate. You will comment, and what 3 things do we monitor when the patient is on magnesium sulfate. And also please comment in the chat box what is the antidote for magnesium sulfate toxicity. I repeat, what is the antidote for max sulfate toxicity? You will comment 3 things what we monitor and what is the loading dose of max sulfate what we get. Is it clear? So pre-monitory symptoms, please remember OB, easy, है ना, जब मैं हूं ना, and when these things are present, you never wait and watch. This is impending eclampsia. नेक्स्ट वेरी इंपॉर्टेंट MCQ. यहाँ पे अगेन स्टूडेंट क्या पढ़ेगा? क्वेश्चन डायरेक्टली एंड डायरेक्टली आंसर मार्क. कि सर 48-year-old, वेरी गुड, पैरा 3 लिविंग 3, फैमिली कंप्लीट, मेनोरेजिया फॉर द लास्ट 3 months, हिस्ट्रेक्टमी. ना रहेगा बास, ना बजेगी बांसुरी. यस और नो? Wrong. Then some student will say fibroid, so myomectomy. Again wrong. Please understand this, that here a 2 centimeter anterior wall subserous fibroid is a extra information which is a useless information given to you just to confuse the student. Why? Because we should know that sir, when a patient is having menorrhagia, a 2 centimeter chintu, 2 centimeter anterior wall subserous SS, a 2 centimeter subserosal fibroid can never cause menorrhagia. बात समझ में आएगा? So this fibroid is not the cause of menorrhagia or heavy menstrual bleeding. So this fibroid is not the reason for heavy menstrual bleeding. And she is 48, so she is perimenopausal. What is the dictum? So sir, then what is the cause of menorrhagia? Yes, sir, the cause of menorrhagia is something inside the endometrium. And whenever I have a perimenopausal patient with heavy menstrual bleeding, never directly, I'm not saying don't do hysterectomy, but never directly to hysterectomy. Why? Because please understand this, whenever there is a perimenopausal patient, you need to rule out. What is the rule? Rule out endometrial hyperplasia and endometrial cancer first. Clap. Is this understood? You need to rule out. Okay, why? Because sir, if I remove the uterus and the histopath report comes out to be cancer, I have done an inadequate operation. Why? Because sir, for menorrhagia, I will do a simple hysterectomy. But if it's a cancer, I have to remove the uterus, fallopian tube, ovary, lymph nodes, all that, radical hysterectomy. तो कौन सा ऑपरेशन करना है? Simple, radical, जैसा which dosa, सादा डोसा, मसाला डोसा, which operation will I do? Will depend on what my histopath is. So what is the dictum? Sir, HPE is mandatory. Please write down. HPE मतलब histopathological examination of the endometrium is mandatory. So never directly go for hysterectomy. Myomectomy has got no role. Never directly hormones. And what I will do is DNC. एक टुकड़ा lining का, scrape off the lining, put it in the microscope. So either I can do a DNC or a endometrial biopsy, or even a hysteroscopy, and biopsy is important. Endometrial biopsy has to be done because HPE, histopathological examination of the endometrium, is mandatory in a perimenopausal age. Why? To rule out endometrial hyperplasia, endometrial cancer first. Then of course, if it's a cancer, I will do a hysterectomy. If it's hyperplasia with urticaria, also I will do hysterectomy. And suppose if all that is not there, then I can also use in Mirena or LNG IUD to control menorrhagia. So then multiple options are available. Is it clear to all of you? So either a DNC or a hysteroscopy and biopsy. Biopsy is the most important. Endometrial biopsy has to be done because HPE is mandatory and why I do HB to rule out endometrial hyperplasia, endometrial cancer first. Is it clear? So in this question, a 2 centimeter anterior wall fibroid is just given to you to confuse. It is not the cause of menorrhagia. This will not cause menorrhagia is important logic. So sir, something is in the lining and the endometrium which you need to rule out first. Is it clear to all of you? Is it clear? And please tell me, if I put a LNG intrauterine device, I can put in to control menorrhagia, I can put in a Mirena LNG intrauterine device. Please comment in the chat box, usme total LNG is how much and how much LNG is released per day. I repeat, when I put in a LNG IUD in a patient to control menorrhagia, we can, if there's no cancer, we can put it. Then what is the total LNG and how much LNG is released per day? Please tell me in the chat box. Again, a very important clinical case. All these, my dear students, short repeat hone wala hai. Primary amenorrhea, okay, and USG, absent uterus. Now, my dear student, I am going to give you a mantra that whenever we have a primary amenorrhea, and along with it absent uterus, please understand this, in whole of gynac only 2 options are possible. Only 2 options are possible. So don't even look at option 3, option 4. Primary amenorrhea, absent uterus. One possibility is RMKH, Rokitansky-Meyer-Kushner-Hauser, also called as Mullerian agenesis, and second possibility is androgen insensitivity syndrome, also called as testicular feminization. Dono ke karyotype, please tell me what is the karyotype for RMKH. Comment in the chat box. What is the karyotype over here? Also please comment in the chat box. So please understand this, in the whole of gynac only these 2 things, androgen insensitivity or RMKH. Don't even look option 3, option 4. Turner syndrome, uterus is present. Small chin to hypoplastic. Kalman syndrome, also uterus is present. Okay. Also please comment in the chat box what is the new definition or new criteria for primary amenorrhea. What is the age group criteria? Is it 14, 16 or 13, 15? Please comment in the chat box. What is the new definition of primary amenorrhea? Okay. So sir, I have primary amenorrhea, I have absent uterus, only these 2 things are there. Of course, karyotype I will come to know, but what? Now please understand this. Breast is not a difference. Breast is not a difference. Breast is well developed here also, here also. So that is not important. So यहाँ पे दिखा है breast well developed. Very good, very good. Breast is well developed in both the cases. कैसे याद रखना है? क्या है important clue? Yes, please understand this, that even in females, the axillary and pubic hair is androgen dependent. So RMKH is a normal female. The gonads presents are ovaries, and ovary will secrete testosterone, and therefore when we look at the axillary and pubic hair, that will be well developed in the first column. But here, sir, it is androgen insensitivity. The testosterone cannot act. The testosterone, there's a receptor level problem. The testosterone cannot act even though testosterone is present, and therefore axillary and pubic hair is either absent, or to make the question tougher, they may even say sparse. But at your level, remember, axillary and pubic hair absent. And that, my dear student, you can see absence of axillary and pubic hair, and therefore the answer is androgen insensitivity or TFS. And one more thing, what will happen? Sir, here the gonad presents are ovary. The gonad present is ovary, and this is testicular feminization. So gonad present is testes, but sir, descent of testes is androgen dependent, and therefore testosterone cannot act in the second column, and therefore testes are undescended. They are in the inguinal area. And that, my dear student, what is that lump felt in the inguinal area? Yes, sir, that is the undescended testes. Is this understood to all of you? So I repeat, primary amenorrhea, absent uterus जैसे यहाँ पे दिया है, and absence of axillary and pubic hair is my androgen insensitivity. Suppose if I just twist the question, and if I write primary amenorrhea absent uterus, this lump wala line I remove. And instead of well-developed breast also I keep, and instead of absence. Now tell me the answer. If I write axillary and pubic hair well-developed plus. Now what is our answer? Yes sir, now the answer becomes RMK. Chokotali. So one word. Presence of axillary pubic hair, answer becomes RMK. But absence of axillary and pubic hair, answer becomes AIS. Chokotali. So please comment in the chat box what is the age criteria for primary amenorrhea. Two definitions, primary amenorrhea, and when it's absent uterus, I told you keep off only these two things in mind. Don't even look at option 3, option 5. I've told you the clue kaise further differentiate karna hai. Clap if you're enjoying the session. Please share this video with all your friends and colleagues. Hype this and download the OGGuru app. And my dear student, if this one video of 45-50 minutes is going to benefit you so much, imagine when you listen to my actual lectures. OBGY will become your most favorite subject, most scoring subject is my guarantee. Okay, what should be the next course of action? We have got a lady who has reached 36 weeks pregnancy, prosthetic valve. Okay, for mitral stenosis. So she has undergone mitral valve replacement, and it is a metallic valve in her body. Why am I saying it's a metallic valve? Because that is why she is currently on warfarin therapy. Now what will you do? Okay, so now please understand this, and this is again a very important PYQ. Now please understand this, that whenever a patient has a metallic valve in her body, lifelong anticoagulant is required. The anticoagulant could be warfarin or heparin. Now, which is better? Which is a better anticoagulant? Forget about pregnancy. Yes, warfarin is a better anticoagulant. But warfarin crosses the placenta, heparin does not cross the placenta. So please understand is warfarin is superior, and warfarin is a tablet. And therefore, when the patient is not pregnant, when the patient is non-pregnant, she will be on warfarin. As soon as the patient becomes pregnant, till the first trimester, warfarin is absolutely contraindicated in first trimester. Kya hota hai? Please comment in the chat box. What problem? Conradi syndrome. Warfarin, what Conradi syndrome hai? Kya organ? Please comment in the chat box what organs are damaged. Warfarin is a teratogenic drug, and therefore we have to keep the patient on heparin. So WH. Now after the first trimester is over, from 13 weeks till 36 weeks, patient can again go back to warfarin because warfarin is superior. So once the first trimester is over, first trimester matlab till 12 weeks, she is on heparin. Then from 13 to 36 weeks, she is on warfarin. Now it is important. Please understand this, after 36 weeks, anytime the labor can start. And then I told you, if the patient is on warfarin, more bleeding for the mother, and since warfarin crosses the placenta, the baby, while passing through the mother birth canal, baby can have also internal bleeding and bruising. And therefore, after 36 weeks till delivery, the patient should again be on heparin. Clap. That is the answer. And after delivery is done, after delivery or with breastfeeding, there is no problem with breastfeeding or postpartum, she can again be on warfarin. So you do not even have to mug it up. It's exactly alternate WH. The trick kaise yaad rakhna hai? After delivery, I'm writing it as postpartum. Okay. The trick is only one which you remember, my dear student. Trick is only one, that just remember one thing. Okay, sir, beginning of the pregnancy matlab first trimester T1, she is on warfarin, and the last 1 month, ending of pregnancy. So beginning pregnancy, ending pregnancy, it is heparin. Rest all is warfarin. Thokotali. Isn't it? Ending, last 1 month. So first trimester, heparin, and ending, because anytime now labor can start and delivery can happen, she has to be on heparin. So now what is the answer, my dear student? Yes. Do I continue warfarin? Wrong. Do I continue warfarin and aspirin? No. Do I stop warfarin? Yes. But then do I start aspirin? No. So stop warfarin and start heparin. That is the answer. Is this understood to all of you? Clap. Okay, so when there's a metallic valve in the body, when the patient is not pregnant, we can give her warfarin. In the 13 to 36 weeks also warfarin is okay, and postpartum after delivery also warfarin is okay. Entire first trimester warfarin is absolutely contraindicated, and close to labor and delivery after 36 weeks again she has to be on heparin. Is this understood to all of you? New style question, match the column. When the student get this question, they get panic. Okay, what is it? Hormonal profile with a patient of amenorrhea. Now, my students love this concept. What is the concept? Please understand this. Master and servant relationship. Master and servant concept you should know. Okay, pituitary is the master. Pituitary is the master and ovary is the servant. Isn't it? Remember this. So now, if the servant at your home is not working properly, what will, if the servant is not working properly, what will the master do? Master will shout more loudly, कि बाबा काम करो, काम करो, काम करो. Isn't it? So whenever the servant function will go down, pituitary secretes what? Primarily first FSH and then बाद में LH also. So when the servant function is going down, when the ovarian function is becoming less, what happens to the master secretion? FSH? Inverse, yes, increase, FSH बढ़ेगा. So ovarian function decline, FSH बढ़ता है, and therefore finally when ovarian function completely over, that is menopause, FSH is the highest. And clap, what can we get? And that FSH comes in the urine. And what hormone we can get? What drug we can get from the urine of the postmenopausal lady? Please comment in the chat box. So sir, whenever I have ovarian insufficiency, matlab sir, ovarian function is becoming less, and finally ovarian function completely stop, which is menopause. So both mean the same thing, same hormonal profile. Both में same problem होगा कि sir, when ovarian function is going down, sir, FSH is going to be high, LH is going to be high, but estrogen is going to be low. So D4. Is it clear? Sub में D4, that is fine, but D is 4. I repeat, कि sir, when the ovarian function keeps on going down, of course estrogen will go down, even progesterone will go down, because then she will not ovulate. So estrogen also low, progesterone also low, okay, or absent, but the FSH will increase and then LH will also increase. And therefore please understand this, whenever the lady is postmenopausal, FSH is very high. Is this understood to all of you? Now, what is the problem, or what will you see if the master himself is sleeping? If the pituitary is fired, so if the pituitary is fired, pituitary में ही problem है, तो FSH, LH both will become very, low, isn't it? Master himself is only sleeping. What is that? Yes sir, Sheehan syndrome. Please comment in the chat box, Sheehan syndrome क्यों होता है? It's a postpartum pituitary necrosis. Yes, it is pituitary necrosis. When does it happen? Which complication? And please comment what is the earliest symptom. So the Sheehan syndrome में low FSH, low LH, and then obviously because master is not functioning, ovary is also not functioning, estrogen will also be less. So A1 देखो तो दो ऑप्शन आपका आउट हो गया. Okay, A is not 2, A is not 2. Okay, so दो ऑप्शन रूल आउट हो गया. Yes or no? That is how you do in match the column. I repeat sir, it's a pituitary necrosis. So the pituitary gland gets fired, LH will also decrease, FSH will also decrease, of course estrogen and progesterone will decrease. So when we get low FSH, low estrogen, low progesterone, all low, that is Sheehan syndrome. Now what is Asherman syndrome? Sir, Asherman syndrome is a intrauterine adhesion. It's a intrauterine adhesion, isn't it? So here sir, all hormones are normal, master is also normal, servant is also normal. So sir, Asherman syndrome, remember it is a problem is inside the endometrium, all are normal. B2, and that is my answer, my dear student. B3 nahi hai, B3 nahi hai, and that is the answer. Is it clear to all of you? And PCOS we know, yes, the name has now changed. Polycystic ovarian का नाम change हो गया, polyendocrine metabolic ovarian syndrome, PMOS. What are we going to get? Yes sir, LH is going to be on the FSH-LH ratio is changed. FSH is normal, but LH is increasing, and estrogen is also on the, it's a hyperestrogenic, hyperandrogenic state. Even testosterone is also elevated. So C3, D4. Yes, absolutely, this is the answer. I repeat, whenever it's a ovarian insufficiency, LH FSH is going to increase, but estrogen is going to be going down. Okay, so servant problem जब है, ovarian insufficiency है, तो master will secrete more and FSH will be more, estrogen will be low. And जब master का problem है, तो FSH will be down. And endometrium problem is there, Asherman syndrome, all hormones, because the problem is not with the pituitary or the ovary. Asherman syndrome में all hormones are normal. Okay, so Asherman all normal, very important. Is it clear to all of you? That's extremely important question. Yes. Hysteroscopy, very, very important. Now, totally student have confusion between hysteroscopy and laparoscopy. Let me for once and for all solve it for you. My dear student, laparoscopy is a terrace view. We are putting in laparoscopy, sir, we put in a telescope through the anterior abdominal wall. So, I will see the everything from, it's a outside view. I will see the uterus, I will see the fallopian tube. Okay, I can do, please come, I can see the fallopian tube, I will see the ovary, and all that I can see in laparoscopy. Please comment in the chat box. When I do laparoscopy, I can do a gold standard test for tubal patency. What is that test? What is the gold standard test for tubal patency? Laparoscopy के साथ क्या करते हैं? What dye we inject? We check whether that dye is coming out or not. And so laparoscopy. Okay. Hysteroscopy, sir, is inside the classroom. Okay. We put in a telescope through the cervix into the uterus to visualize the cavity of the uterus and problem inside the cavity. So laparoscope cannot see that, because laparoscope sees only the outer surface. Common sense. जब आप ये देखो, laparoscope जब आप uterus को आप outer surface देख रहे हो, how will you know what is inside the uterus? No. So all of you look on the board. Asherman syndrome, of course, yes. Sir, Asherman is intrauterine adhesions. And with the hysteroscopy, I can not only diagnose it, I can simultaneously treat it. What I can do, sir, I can see I'm doing the surgery. We can do hysteroscopic adhesiolysis. Okay. So, agar, sir, if there are adhesions, hysteroscopy will be helpful. Yes, patients can have endometrial polyp or a submucosal fibroid, which can cause menorrhagia. And also, sir, the patient can have a septum. Patient can have a septate uterus. Patient can have a septum projecting into the cavity. So, laparoscope se wo nahi dikhega. Laparoscope is the outer view. Okay. And this is hysteroscope is the inside view. Thoko tali. So, laparoscopy is the terrace view. Hysteroscopy is inside the classroom view. So, I can not only diagnose septum, I can also do a septum resection. Is this understood? So, sir, hysteroscopy is indicated in a patient of Asherman syndrome, intrauterine adhesion. Please comment. Why do we get Asherman syndrome? Excessive what? Okay, menorrhagia. Yes, sir. There could be a endometrial polyp which I can cut with hysteroscope. Or I'm writing SM, submucosal fibroid, which can also be detected by hysteroscopy, and septum resection of course requires hysteroscopy. Again a PYQ. Answer is endometriosis. Why? Because sir, endometriosis, everything is outside. Please comment in the chat box. Endometriosis में क्या होगा? Sir, I will see chocolate cyst. There could be adhesions. There could be adhesions between the tube and the ovary. There are matchstick burnt spots. black spots. These are called endometriotic lesions. So all this can only be seen with laparoscopy. Powder burnt spot, matchstick burnt spot. And also please comment, what else do we see? 2-3 more findings. We can get blue spots. Usko kya bolte hain? Blue spots, purple spots. Okay, red raspberry, purple raspberry, all that we can see. So all these are endometriotic lesion which can only be seen with laparoscopy. Okay, so endometriosis, my dear student, very important, will require a laparoscopy. Laparoscopy is the investigation of choice and not hysteroscope. Hysteroscope के लिए खाली 4 याद रखना है: septum, endometrial polyp, submucosal fibroid, adhesions, Asherman syndrome. This A, B, C requires hysteroscopy. Is it clear to all of you? Yes, laparoscopy will require for endometriosis. Again, a very important clinical case. Patient is obese, fine, acne, hirsutism. So what is it? Yes, irregular periods. LH, I told you, higher side. FSH, look at the ratio of FSH to LH. We are getting 5:15, so 1:3, inversion. So what are the features telling you? Yes, PCOS, polycystic ovarian syndrome. Long time ago I have told you it's a misnomer. Okay, and now we know the new name is PMOS, polyendocrine metabolic ovarian syndrome. And patient is anxious to conceive. What is the best treatment for this patient? Now please understand this. First of all, please comment in the chat box what criteria we use for diagnosis of PCOS. What criteria we use, वो आप comment करोगे chat box में. Okay, why am I making as the diagnosis of PCOS? Because sir, obesity दिया है. Clinical feature, obesity is there, acne, hirsutism, so elevated testosterone, FSH ratio also altered, irregular periods. Now, one word answer. Directly, many students, when they think of this PCOS, and of course, there is infertility, the patient is married for last 3 years, many of them will directly say clomiphene. Wrong. And again, some students will say letrozole again, and I'll tell you why wrong and what it is. Okay, so please pay attention. Now, whenever the patient is having PCOS or PMOS, of course, lifestyle modification is very important. Lifestyle changes, diet, exercise, yes. Okay, and what else can I give? Metformin should be given to tackle the problem of insulin resistance, isn't it? Yes, along with diet, lifestyle. Now, why is there infertility? Can you tell me why is there infertility in a patient of PCOS? Because of, sir, an ovulation. And therefore, I have to go for ovulation induction. That is the answer over here. So please understand this. OC pills are not useful over here in this patient. OC pills are given if the patient wants treatment for acne, hirsutism. So right now, patient is anxious to conceive. She is planning pregnancy. So right now, there is no role of OC pills as of now. Okay. And remember this, my dear student, letrozole is the first drug of choice for ovulation induction, in a patient of PCOS. Letrozole is giving better results, more ovulation rates, more live birth, and clomiphene was old. So clomiphene was the drug of choice. It is not now. Is this clear? And therefore clomiphene is also out. And many students will directly mark letrozole or C as the answer. Not completely wrong, but not completely correct also. Why? Because yes, sir, letrozole is the first drug of choice. Letrozole I will give. But along with it, shouldn't the patient do diet, exercise, lifestyle changes, and metformin also? Yes, sir. Metformin will be given to her because, sir, she is obese. There is insulin resistance. So, metformin also will be given. And common sense case, sir, they are married for 3 years. any infertility, I have to evaluate the partner also. अगर husband का sperm count low है, कम है, speed कम है, so isn't evaluate the male partner also required in a patient of infertility? Of course, yes. And therefore D, my dear student, C is not completely wrong but not completely correct, and D is much better than C as the answer. If D is not in the option, then C is the answer. Is it clear? So sir, letrozole I will give her for ovulation induction. Metformin will tackle the problem of insulin resistance and help her ovulate better and target obesity, and of course evaluate the male partner also. So D, my dear students, is a much rounded and a complete answer. So D is a complete answer, and therefore D is better than only C. Clomiphene is wrong because letrozole is the first drug of choice. Please comment in the chat box, what can I do if letrozole nahi kaam karta hai, then clomiphene yes, and what is the third option? Please comment in the chat box. There's one more drug. There's one more third drug, very powerful, which I can give injections. Please comment in the chat box, what is that third drug available if letrozole clomiphene fails? Is it clear for a patient of PCOS? Okay, and acne hirsutism hai, to OSIP is lagega, not now. Is it clear to all of you? Yes. Again, a very important, see, simple one-line PYQ and student make a mistake. All are components of BPP except. Now, please tell me in BPP, it is a, first of all, it's a test for fetal well-being. Manning score. It's a Manning score. Totally, there are 5 components. Please comment in the chat box, what is the maximum score of BPP? Anybody? BPP का maximum score कितना हो सकता है? 20, 40, 100, 9, 7, 11, 1000. What's the highest score of BPP? Now, what is it in BPP? And how is BPP done? Yes, NST is a part of it. So, sir, first I will do NST and then remaining 4 things I will do. Now, anybody, when I tell you this fetal kick count and BPP mein, in BPP, my question to all of you, chalo, in BPP, who will count the fetal movements? Who will count the fetal movements? Anybody? Many students clean board. Who will count the fetal movement in BPP? Mother, father, neighbor, intern, doctor. Okay? Intern has to study for the NEET PG. So, intern has got no time to count the fetal movement. Neighbor, if the neighbor is counting the fetal movement, बहुत गड़बड़ है, बहुत गड़बड़ है, और बहुत गड़बड़. Why is the neighbor counting the fetal movement? Okay, and many students will tell me, okay, sir, mother will count the fetal movement, and that is wrong. Clean bold. Please understand this. The mother counts the fetal movement at home. That is FKC. Sir, in fetal kick count, the mother counts the fetal movement at home. That is not a part of BPP. Sir, BPP requires NST plus ultrasonography. Is it clear? Sir, to do BPP, you require to do NST for 20 minutes, and along with NST, the ultrasonography has to be done for 30 minutes. And on the sonography screen, the sonologist will count the fetal movement. Is it clear? So basically, yes, it is fetal movement. This is a trick MCQ, and this question came PYQ, all students clean word. Okay, what all do we check? What all do we check in BPP? 5 components. So we look at fetal movements. There should be 3 body movements. Fetal tone we check, like a amniotic fluid, and also fetal breathing movements. So please remember this: NST, fetal breathing movements, fetal tone, this, and this is seen on ultrasonography. Ultrasonography has to be done for 30 minutes to check for fetal movement and fetal tone and fetal breathing. Is this understood? So कहने का मतलब क्या है? This in BPP, it is fetal movement and not FKC. It is not fetal kick count, and therefore that is the answer. Clap. Fetal tone, yes. NST, yes. Amniotic fluid, yes. It is fetal movement. It is a fetal movement which is counted by the Radiologist or the sonologist? Thoko tali, clap. So sonologist or radiologist will check for fetal movement in BPP and not the mother. Mother counts the fetal movement at home. That is called as FKC, fetal kick count, which is not a part of BPP. समझ में आ गया? Sir, BPP में fetal kick count नहीं है, fetal movement is there. Is it clear? I'm writing it's not FKC. So 5 components. Please tell me what is the maximum score of BPP. Okay? Is it clear to all of you? Next, very important MCQ. Again, short. We have got a patient who has come to us at 12 weeks primary. Dual marker test is high risk for Down syndrome. So now first of all, tell me what the components are. It's a dual marker test. Is what kind of a test? Anybody? Is it a screening test? It's a confirmatory test. Okay. So the dual marker test is there. The dual marker test. What are the two components? Sir, HCG and PAP-A. HCG is human coronary gonadotropin, PAP-A pregnancy associated plasma protein A. Okay, PAP-A, PAPPA. I repeat the full form, pregnancy associated plasma protein A. It is a screening test. Now please tell me what is the interpretation. Please comment in the chat box. Please comment in the chat box. What happens to the value? HCG will be higher normal, PAP-A will be higher or normal, okay, or lesser than normal. What happens to the levels of HCG, PAP-A in dual marker test when the baby is having Down syndrome? Okay, now the important point, what the mistake student make is that please understand this, the dual marker test. This dual marker test, or whether it's even triple marker, quadruple marker, the dual marker test is a screening test. That is the most important point. It is not a confirmatory test. It is a screening test. For many students directly say, oh, dual marker, high risk for Down syndrome, MTP. Wrong. Please understand this, never directly do MTP. Yes, because the Down syndrome, there is no treatment. So for Down syndrome, yes sir, MTP will be required. Yes, but please understand this, can never directly do MTP. Why? Because a dual marker is only a screening test. Dual marker will tell you that it is low risk. That means almost normal. Dual marker is low risk for Down syndrome. Very good. If the dual marker test is high risk for Down syndrome, that is the question. So never directly do MTP, and when one screening test, many students will mark quadruple marker test. Again wrong. Please understand this, sir, when one screening test is abnormal, quadruple marker test is also a screening test. Please comment in the chat box, when do we do it? When do we do it? Anybody? Yes. So dual marker test is done around 12 weeks of gestation in the first trimester. Quadruple marker test कब करते हैं? Please comment in the chat box. Now understand this, that when one screening test is abnormal, there is no point doing another screening test. Why? Because suppose that screening test report is normal. What will you tell the patient? Relax ho jao? No. I need to basically remember that whenever the screening test, dual marker, as I told you, is a screening test. If it's low risk, very good, that means it is normal. But whenever the dual marker test is high risk, I need to do a confirmatory test. And please tell me in the whole world, what is the confirmatory test? Yes sir, karyotyping. Karyotyping is the confirmatory test, because you, me have got 46 chromosome. I want to detect baby with 47. Now again, karyotyping sir can be done by two techniques sir. Either I can do chorionic villus sampling or I can do amniocentesis. Is this understood to all of you? Again remember this. So many information. Again remember, so chorionic villus sampling is a confirmatory test which I do in the first trimester T1. 12 weeks ka, after 10 completed weeks, 11 to 13 weeks ke beech mein. Remember this. Chorionic villus sampling is test done between 11 to 13 weeks after 10 completed weeks. And amniocentesis sir is done in the second trimester, roughly around 16-18 weeks. Is it clear to all of you? So now we know the answer, sir. That sir, when the patient is a dual marker test high risk or dual marker test positive, we cannot directly go and do MTP, and similarly there is no point doing another screening test, the quadruple marker test. What am I supposed to do? Sir, we are supposed to do a confirmatory test by karyotyping, and we are how many weeks? 12 weeks, and therefore the answer is chorionic villus sampling. Is this understood to all of you? If the question was that the patient is 16 weeks, suppose one more variation in the question, the same question. Instead of this, see, clap if you feel happy. If I make this 16 weeks, if I say, okay, sir, patient is 16 weeks and the triple marker test or the quadruple marker test is positive. Now what is the answer? Yes, sir. Now we are 16 weeks. We will do now amniocentesis. Chokotali. Is it clear to all of you? So I'll make the question original so there's no confusion. Okay, sir, we are 12 weeks pregnant and dual marker test is. So see how one digit. Clap if you feel happy. One digit change, answer change. 12 weeks ka 16 weeks kar diya. So then CVS cannot be done. I have to go for amniocent. Is it clear? So sir, right now we are 11 to 12 weeks. Dual marker test is positive. I need to not directly do MTP and do not do amnio right now because we have 12 weeks only. So we will do chorionic villus sampling, which is a confirmatory test. Chorionic villus sampling is done in first semester and karyotyping is a confirmatory test. If the patient is 16-18 weeks, generally 16-18 weeks diya hoga. Then anytime after 14 weeks, 16-18 weeks, then we can do amniocentesis. Is this understood to all of you? So every word is important and you should know it. Now again, identify this IBQ, identify the type of deceleration. Now first of all, is it a NST or a CTG? Remember this trick. When you see only a single graph, when you see only a single graph, that, my dear student, is NST. If you see two graphs, baby heart rate and along with it contraction, that is CTG, cardiotocography. So here, sir, we are seeing two graphs. This is the baby heart rate going down. This is uterine contraction. So this is the fetal heart rate. This is the toco. Toco matlab what? Not thoko tali. Thoko matlab uterine contraction. Similarly, this zigzag which we are seeing, zigzag is the fetal heart rate, and this we are seeing is the contractions. Now here, if you see, my dear students, this is a very tough IBQ. Dhyan se sunenge. What is happening is that the heart rate is going down. I will tell you two things. Okay, please understand this. Whenever you will look at the contractions first. Okay, you will look at the contraction. So ye ek contraction aaya, suppose ye ek dusra contraction. Okay, now when the fetal heart rate starts to go down, after, please understand this, the contraction has already started, reached the peak, and then the heart rate has started to go down. And sir, the contraction is already over and then the heart rate has recovered. Can you see? So sir, heart rate starts to go down well after the contraction has already reached the peak, and after the contraction is over, then the heart rate has had the recovery. This is late deceleration. Which we see in which condition? Please comment in the chat box. Late deceleration indicates what? Okay, so again, sir, here what will happen? The heart rate starts to go down, and sir, the heart rate will recover. Sir, the contraction has ended over here and the heart rate recovery is afterwards, which you can see over here clearly. See, here the contraction ended and uske baad heart rate is recovering over here. Same thing is over here. So contraction is already over and uske baad contraction is already over and then the heart rate is going down. So it is coming after the contraction. So all these decelerations are in relation to the contraction. This is a late deceleration. Late deceleration is seen in which condition? Please comment in the chat box. Please also comment when do we get early deceleration. Early ke liye I am giving you one more trick. Early is a mirror image. What is the meaning of mirror image? Sir, early mein kya hoga? Early में ये होगा. So this is your late deceleration. One more bonus MCQ. Again, if you look at the contractions. So sir, early में क्या होता है? Please pay attention. Early में the baby heart rate, when the contraction starts, the heart rate starts to go down. When the contraction over, the heart rate recover, and this is the peak. The peak of the contractions and the lowest point of heart rate, lowest is called nadir, will correspond. That is early deceleration. Clap. Is it clear to all of you? So again, just to show you over here again the contraction start, baby heart rate goes down. In between there will be a zigzag pattern. Okay, clear to all of you? So this is the baby heart rate, and again there is a this. So when you get this pattern, can you see mirror image, the baby heart rate and this? So contraction over, heart rate recovery. Contraction start, heart rate starts to go down, and this peak and this lowest point are meeting or facing each other. This is, my dear student, early deceleration. यहाँ पे the heart rate going down and recovery after the contraction is over, that is the late deceleration, which is this very very important MCQ. Late किस में दिखता है? कमेंट करेंगे. Variable early किस में दिखता है? कमेंट करेंगे please in the chat box. And my dear student, look at this beautiful colored notes. Every student has told me, since we have seen your videos, if you have read, you have seen my videos, you can revise the entire notes in 2 hours time. Guarantee. There's a notes read along session where I, along with the students, we have read the notes just in 2 hours time, entire beautiful colored notes. And my dear student, please see all the testimonial. Imagine if this 45-50 minutes video has benefited you, how much you will benefit. Just give me 4 days time. There's still enough time. You got 3 months. There is 3 months. Sir, OBGY bilkul makhan. All questions. It took exactly 2 hours. That's what I told you. Oh, I wish you had taught us all the master the OBGY OGGuru way. All 100%, sir, they can score in the examination. So questions came the way exactly you taught. We were most confident with your OBGY. Okay, and sir, OBGY questions, all questions came from your lecture and from your videos. So my dear student, do not waste time. As I said, OBGY is a single most important subject. 20 to 22 MCQs are going to come in it, and just in my guidance, 4 to 4.5 days time, you can get beautiful theory lectures, MCQ discussion video, beautiful handwritten notes. Most importantly, my personalized timetable guidance and mentorship available on WhatsApp, and call on this number. Download the OGGuru app. Only in 1349, launch 30 is the discount coupon. NEET PG combo is available, and just 4 days. I can assure you that if you are stuck up at the score in OBGY 10, 11, 12, just 4 days time you give to OBGY, 4.5 days, the score is going to jump up to 18, 19. All my students get 20 on 20. 8 marks more. 32 marks more, my dear student, or even 25 to 32 marks is a difference between rank of 4,000 and 40,000. And tremendous rank jump is possible. It's a difference between score of 400 and 4,000. So do not waste time. Just download the OGGuru app and enroll in the masterclass. OBGY will become your most favorite subject, most scoring subject is my guarantee. And your OBGY score will, when you walk out of NEET PG examination, you will message me and call me and tell me, thank you, sir. Among all 19 subjects, my best performance in OBGY. You can easily get 20 on 20 in OBGY, which all my students get every year. Beautiful conceptual lectures and MCQ discussion videos are there, which you can easily finish off in 4.5 days time. Still there is 3 months to your NEET PG with free extension till the NEET PG examination you're going to get. So just enroll in the 3 months combo package. And do not forget to follow me on Insta. Please hit the subscribe button. Please follow on YouTube also, so that you can get and switch on the notification. Hype ka option to hype this video, and the PDF of this will be available on Telegram. So subscribe to the YouTube channel and Insta also, and feel free to get in touch with me on phone and WhatsApp on this number, and WhatsApp me for your timetable guidance. OBGY, as promised, will become your most favorite subject, most scoring subject. Best of luck.